Hi everyone. In this lecture we're going to be talking about Chapter 9 in our Fuller's textbook, Surgical Technology Principles and Practices. And Chapter 9 is going to cover the principles and practices of aseptic technique, which should not be unfamiliar to you. We've had discussions about them before, so we're just going to kind of fill in some of the blanks. I just want to suggest that all of you review the terminology that's at the front of the chapter. There's a whole bunch of words here that we're probably pretty familiar with, but just review them to make sure that you have an understanding of what each of them mean. So according to the book, the definition for aseptic technique is methods or practices in healthcare that reduce or prevent the spread of infection. And so we've had several conversations about how the surgical technologist plays an integral role in maintaining sterile technique, making sure that microorganisms don't get introduced into the operative field. These things that we do, these skills that we perform, are not the average type of skills that we perform on a daily basis. So they're going to be weird and strange and foreign and unusual to us in the beginning when we're first starting out. Some of you had mentioned how the closed gloving looks really weird and difficult, and it is weird. It's not something that we do at home. If you were applying for a job as a bus driver, you would have some skills that you could take and apply to being a bus driver, because we all know how to drive a car or a truck or a motorcycle or something like that. But aseptic technique is a little bit different. So I just want to reiterate that the only way that we're going to get better and hone our craft and improve is just through practicing. And as best you can, try not to be too hard on yourself in the beginning and give yourself some grace. You're going to see one, and then you're going to practice it, right? And then you're going to help somebody else do it. In surgery, we say see one, do one, teach one. And that's the approach that we're going to take in the lab as well. You're going to see it, you're going to practice it, and then you'll probably help somebody else hone their craft. And we're going to continue in this manner. So just be brave and jump in. Don't be afraid of making mistakes. This is the place to do it here in the OR lab during our training. So sources of guidelines and standards. There are these rules and regulations that we've been talking about for some time now, as far as aseptic technique and principles and practices. And these standards are established through research and science. Something we refer to in medicine and other branches of science as evidence-based practices. And evidence-based practices are kind of three components, and where those components come together, that's where we establish an evidence-based practice. So we're looking at best evidence from research, all right? Hand washing, it's a thing. We know that it's a thing that helps to stop the spread of diseases. How did we find that out? Well, we did some tests. We, washed our hands and touched some Petri dishes, or we didn't wash our hands and touch some Petri dishes, and we did some experiments in micro, and we found that, even in those most basic types of experiments, that's a thing, right? So part of it comes from research. The other part comes from clinical expertise and experience. You're out in the field, you're doing it day in and day out, and you see what works and what doesn't work. And then that last component, of course, we need to think about our clients or our patients, their perspective, what feels comfortable for them, and get their feedback and their input, all right? If it has to do with some sort of clinical perspective. There are several agencies and organizations that have also help to contribute to these evidence-based practices. They are the AHRQ, the Agency for Healthcare Research and Quality, the Association for the Advancement of Medical Instrumentation, AMI, and then there's also ANSI. So AMI, ANSI, they kind of go together and they establish these practices as far as how we process our instrumentation and our equipment and sterilization parameters and all of those things. And of course, the Center for Disease Control needs to get their 2 cents in there, as well as OSHA, the Occupational Safety and Health Administration. And then lastly on this list, SHEA, which is the Society for Healthcare Epidemiology of America. So when we say something is sterile, it either is or it isn't. Something is sterile, that means that it is completely devoid, completely free of all living microorganisms, including the pesky spores. Okay, so there's no gray area here. Either something is sterile or it's not sterile. Nothing is ever partially sterile. So I put this picture in here just to kind of jog our memories about the sterile field, right? The sterile field is a physical space and it is occupied by the draped patient. Remember, when we establish our sterile field, we start opening things at the back table and we work outwards towards the periphery. But once we get that patient draped, they become the center of our sterile field. Some other important concepts to remember, and we've talked about quite a few of these things already. The first being surgical site infection, which we talked about a lot when we were in our microbiology class. How do surgical site infections occur? There's several different ways. There's via personnel. It could be contaminated instruments, supplies, or equipment. It can also be a result of the environment. When we talk about contamination, we're talking about when something sterile becomes not sterile. Maybe it comes into contact with an item that isn't sterile. Remember, if sterile touches non-sterile, then we refer to that as a contamination. If something is grossly contaminated, that means that there is a highly infective source, and that could be an example of a ruptured appendix, let's say, or some sort of ruptured abscess in the abdomen. It could be spilling of the contents inside the intestinal tract as well. It could be something like bioburden. Bioburden is when there's tissue that has been left on an instrument. It's gone through the sterilization process and you get it out of the tray and there's a big piece of bone or there's a hunk of something on it. That would also be considered a gross contamination. Various barriers help to prevent contamination by establishing a separation between the sterile and the non-sterile. And there's a few ways that we do that. One, we've talked about quite a bit already, is physical barriers. Physical barriers like drapes and gowns that are sterile and help to provide a barrier, right? We put a cover on the back table that is a barrier between the table's non-sterile surface and the surface of the drape. There's also chemical barriers. Chemical barriers are produced by something called that residual effect. And in regards to antiseptics, right? So we talked about how some of the prep solutions that we use have a residual effect, and that means they keep working even after we've applied them to the skin. And then lastly, distance, or this textbook refers to it as space. Space is another type of barrier, or distance, all right? Remember how we said we want our sterile stuff to be 12 to 18 inches away from anything that's not sterile, okay? We don't want a non-sterile person reaching over our field. Those types of things constitute distance. And then lastly, our surgical conscience. I don't have to tell you what a big responsibility this is and how it takes a fair amount of courage and bravery to call things out in surgery, especially when it's maybe an environment that you're not familiar with. It's a surgeon that you don't know. It's a nurse you've never worked with before. You're a student starting out, or you're just an entry-level employee. It takes a lot of guts to be able to call out a contamination or report a break in sterile technique. And something inside of us, our surgical conscience, is that thing that that Jiminy Cricket on our shoulder, if you will, that propels us to say something when we notice it, right? A break in technique, or to call ourselves out, right, when we realize something. Because at the end of the day, it's about the safety of the patient. It's not about my ego. It's not about your ego. It's not about being afraid that we're going to get in trouble. And sometimes we do get snipped at, right? Surgeons might get snippy with us, but it's what's best for the patient. And if we can always keep that in perspective, then I think that that will help us. The principles and practices of aseptic technique are listed starting on page 149, and in this textbook there are 16 of them. And we have already gone over them as we went through our micro class. But I will just run through them quickly here, starting with sterile touches sterile and non-sterile touches non-sterile. Again, if a sterile item touches a non-sterile item, that would be considered a contamination. It would be a break in sterile technique. We would call it out. We would fix it. All right, we're always going to make breaks in technique. Now, hopefully, as we hone our craft, those breaks will become less and less and less over time. However, you can be a surgical technologist for 50 years, and there are still going to be times when you break technique, okay? So while reducing the number of times we break technique is important, equally important, and probably even more so, is recognizing the break and fixing it correctly. A sterile item is considered sterile after using methods that are proven and yield measurable results. What does this mean? This means we are looking at several checks and balances, right? We talked about how when we sterilize things, we put a chemical indicator in there. On the outside, there are visual cues as well, right? We look at time and temperature and pressure as far as sterilization parameters, right? Those are things that are going to give us clues and help us to ascertain if this item is sterile. That's what we're talking about there. Sterile drapes, gowns, gloves, and table covers are barriers, right? They're those physical barriers. The edge of any sterile drape is considered non-sterile. Remember, we have that 1-inch margin, and anywhere that a drape or a cover falls away from an edge, it's considered not sterile. We also have to think about how we transfer liquids from off the sterile field onto the sterile field. Once we start pouring, we don't want to stop pouring, right? Once you pop, you can't stop. You don't recap, you don't reuse. My favorite one, when in doubt, throw it out. If you turn to me and you say, well, do you think it's okay? I'm just going to stare back at you, right? When in doubt, you're doubting. You're asking me. If you have doubt, get rid of it, okay? The draped patient is the center of the sterile field during surgery. Sterile gowns are sterile from fingertips to 2 inches above the elbow and from mid-chest to waist, unless we are standing at the bath table or the OR table. Then that parameter can change a little bit. All right, surgical personnel must pass front to front, right? That's the sterile part of the gown to the sterile part of the gown, or back to back, non-sterile part of the gown to non-sterile part of the gown. That just makes sense. Sterile tables are considered sterile at table height, that top surface only. Sterile personnel must remain in the area of the sterile field. Sterile personnel, non-sterile team members may not lean over, reach over, or pass between 2 sterile fields. We don't want that. Keep your sterile things close together to dissuade individuals that aren't sterile from walking between them. If somebody's looks like they're going to reach over your sterile field to give you something and they're a non-sterile member, take a step to the side to the end of your table. You move your body, they'll move their body. Movement is kept to a minimum. Talking is also kept to a minimum. Drapes and linens, we want to handle them as little as possible. We don't want to flap them, shake them, or shift them. Moisture carries bacteria from non-sterile to sterile. We refer to this as strike-through contamination. If something gets spilled on your drape, mop it up really quickly. Discard whatever you mopped it up with. Okay, and then lastly, the sterile field is created and maintained throughout the procedure. Remember, we have to babysit the sterile field. Once we open it, we shouldn't leave it by itself. It gets scared. Personal asepsis and surgical attire, health and hygiene. It is important that we take care of ourselves and that we maintain our bodies properly so that we don't introduce additional microorganisms into the environment where we're working. All right, so if you're sick, don't go to work. All right, if you're sick, don't go to work, stay home. We want to make sure that we cover up our noses, and when we're opening, we protect our skin by wearing our cover-up jackets, right, so that we don't get flakes of our own skin onto our sterile field when we're opening. Daily bathing. Don't you just think it's interesting that the book has to mention daily bathing? But it's a thing, right? We want to bathe daily. We want to make sure that we are clean and fresh for the day. It might also be a good idea to bring some extra deodorant and keep it in your locker, all right? Because this is stressful, and especially in the beginning. You might sweat more than you typically do. Okay, another thing is we want to make sure that we don't wear anything that's heavily perfumed in the operating room. If you have some really foo-foo, smelly good lotion, save that for your days off. You don't want to wear it into the operating room, or your perfume, or your cologne, or your Axe spray, or whatever the case may be. You want to use non-scented stuff because you are working in a really tight environment, close environment with other people, and you just want to make sure that you don't offend them, or they don't have some sort of allergy that you're triggering or whatever. Fingernails. Again, fingernails should be kept short, no longer than a 1/4 inch past the fingertip. We want to make sure that there's no polish, no gel, no acrylic nails, nothing like that on our fingernails. Some facilities do make you cover your tattoos. So PIMA has changed their guidelines as far as covering tattoos, and we don't need to do that anymore. But just be aware that some facilities are going to ask you to cover your tattoos if you go out into the kind of general public of the facility. So what do we wear? We know we wear our scrub suit. We should also have a non-sterile cover-up jacket, cap for our head, something to protect our eyeballs, a mask to cover our face, and shoes that are OSHA compliant, and shoe covers. Okay, those are the things that we need. As far as the scrubs, when you start work at a facility or you're on your clinicals or whatever, they provide the scrubs for you. Okay, so you're gonna wear the scrubs that they have there. Now, a lot of facilities did find that scrub attire has a tendency to walk off, aka a lot of personnel are wearing their dirty, nasty scrubs home. I'm not sure who would want to do that, but apparently a lot of them are or were. So they have designed these, they're almost like scrub vending machines. And you use your badge or you have a special code that is connected to you, and that dispenses your scrub top and your scrub bottoms. And you don't get another scrub top or scrub bottom until you return the ones that you took out before. So, you know, there's a couple reasons why we don't want to wear scrubs home. One is that they're contaminated and they're gross, and who knows what you picked up on those scrubs during your workday. You don't want to take that home and share it with your family. The second thing is it's considered stealing from the hospital. And then lastly, you're not going to get more, okay, if they have that dispensing system, that vending system that I spoke of. New fresh scrubs should be put on at the beginning of your shift, and if they become visibly soiled, they should be changed during your shift. Otherwise, you're good to wear them for your entire shift. Okay? Head covers. There is some disputes about can we wear cloth ones. That's really not an acceptable practice. Home laundering of those cloth caps and or scrubs is not effective to kill the microorganisms and or the spores that could be present that you picked up in surgery. So that is not a really great idea. I would refrain from wearing the cloth head caps just because I don't know what I picked up while I was in surgery on that cap, and now I'm taking it home to wash it in my washer. All right. Some facilities do allow you to wear them and put one of the bonnets over it. As a student, I'm going to ask that you refrain from wearing cloth, just wear the disposable head caps. Once you become an employee, then when in Rome, you can go by their policy, okay? Protective eyewear or face shield. Again, we need to cover our eyes at all times when we're in surgery. You never know when a blood vessel is going to squirt, or there's going to be a splash of some kind, or there's going to be some sort of cyst that's contents under pressure that's going to rupture and, you know, aim for your face. I don't know. We just need to make sure that we always cover our eyes. We always need a mask, and then our shoes and our shoe covers. Here's some images that I put together for you from different types of masks. Now, this mask in the middle I picked because the green ones are a special anti-fog. So if you wear glasses, let's say, and you have trouble that your glasses are fogging up, this, if you were to flip this over behind this area at the top that goes over the nose, there's an adhesive sticky, all right? And so it will stick to your face. In the operating room, we do not wear these little stretchy ones that go behind the ears. We wear the ones like on the top left or the top right that have ties. And when you tie them, you tie the top strings up high on top of the head and the lower strings low as possible around the neck. There are also, the one on the top right has a face shield attached to it. Notice that she's not wearing any type of eyeglasses. She has that shield that serves as the eye protection. So there are masks like that as well. I highly recommend them. The mask in the bottom middle, that's a laser mask. So if you are in a case that's using laser, this is a special mask that helps to filter out those laser particles that go into the air. On the bottom left, these are traditional shoe covers. We should wear shoe covers over our shoes. We should not wear them in the OR and then go down to the cafeteria wearing the same shoe covers. You should discard them before you leave the department and then put new ones on when you come back to the department. Nor should you just kick off your shoes and leave them on there and wear them day after day after day. You should take off your nasty shoe covers at the end of the day, throw them away, and get fresh ones on your next shift. Over to the far bottom right are some knee-high shoe covers. If you are going to be in a case like an arthroscopy or a hysteroscopy or a cystoscopy where there's going to be a lot of waterworks, these are the shoe covers for you. That way your legs and your feet and your socks are all protected from the fluid that's going to be used during the case. When you're removing PPEs, the mask should be removed by undoing the top tie, undoing the bottom tie, and then handling the mask by the ties and not the part that was covering your face. When removing shoe covers, we want to turn those inside out as we're removing them. The gloves, dirty to dirty and then skin to skin, or dirty to dirty and clean to clean. When we remove the gown, I will show you how to remove a surgical gown, but once we get the ties undone, we want to peel it off from us and turn it inside out so that the schmutz is on the inside and away from us and contained. Hand hygiene. So the three main types of hand hygiene that you will encounter in the operating room are first the hand wash, okay, the basic hand wash, that's our bottom right. The scrub, which is on the left of the slide, and then the waterless scrub, or the hand antisepsis, they call it. So we know all about hand washing. We've washed our hands. We know how to do that. We've demonstrated it. Let's talk a little bit more about the traditional scrub. Like I was saying in class earlier, a lot of times the practice nowadays is you come in at the beginning of your shift, you do your traditional scrub, you towel off, and then when you get ready to scrub into your case, you use the waterless. If you leave the department, or if your hands or arms become visibly soiled, you will need to return to that traditional hand scrub, okay? Hand and arm scrub. Now there are two types of traditional scrub methods. The first one is called the counted method, and the second one is called the timed method. Now the counted method is the method that we saw today in the videos and is the method that we will be using when we scrub here at school. That is where you're counting the strokes on each plane. And we talked about each finger is 4 planes and it needs 10 up and down strokes. Okay, so each plane needs that. We need to capture the web spaces. The fingernails are going to get scrubbed for 30 strokes back and forth. All right, the palms in the back of the hand, we're going to do 30 as well. And then as we work our way up the arm, 3 sections, 4 planes, 10 circles on each plane of those 3 sections up to 2 inches above the elbow. That is our counted method. Now, the timed method is the other method, and the timed method, if you have not already guessed, focuses on how much time you scrub each area. All right, so for example, instead of cleaning the nails for 30 strokes, we would focus on the entire hand and scrub it for 2 minutes. Then we would focus on the dorsal and palm side of the hand for 1 minute. Then we would focus on each arm to 2 inches above the elbow for 1 minute. However, this is not the most methodical and effective technique. That is why we are going to stick with the counted method. Now, the surgical hand rub, top right corner for you, is an example of one of the waterless hand scrubs, and it's called AvaGuard. This is a very common one that you'll see in facilities. It has a little foot pump that rests on the ground, and you just step on it with your foot, and when your hand is under there, under the spout, like you see that hand, then it will dispense some of the hand rub into your hand. All right. When you're doing the hand rub, you want to be familiar with the manufacturer's guidelines and follow those. All right. With the fingers of the one hand, now you see this individual has their right hand out in the image and they've put some AvaGuard into their hand. They're going to take their fingers and put them all together, and they're going to rub their fingernails, dip them in, right, about 30 circles or for about 5 seconds into that AvaGuard. Okay, then they're going to spread the antiseptic over their entire hand, wrist, forearm, and elbow, making sure that you cover all the surfaces. Then they're going to get AvaGuard in the left hand, dip their fingernails in for about 30 circles or 5 seconds, repeat the process, wiping it on the hand, down the forearm, covering all surfaces up to 2 inches above the elbow. Then they're going to get one more pump, and they're just going to concentrate on their hands, covering all the planes of the hands, interlacing the fingers, getting in the webs. And I typically stand there and rub mine until it's basically dry. And then you can go into your OR and you don't need to use the towel, you just gown and glove. Okay? We will practice this in the lab. So after we've performed either the surgical scrub or the surgical hand rub, now is time to enter our operating room. If we are wet from the traditional scrub, we are going to go for our towel. If we are dry from the hand rub, we're going to go straight to the gown. So we're just going to focus on the traditional scrub for now. So once you get into the operating room, remember you've left your drips at the sink. You're going to reach onto your Mayo stand quickly and swiftly and only touching your towel and being aware of not dripping onto the sterile gown or gloves that you have there. After you dry your hands, then you will only get the gown. So you're going to reach back onto your Mayo stand, just touching on top of the gown. You're going to grab it, lift it up, take a big step back, orient the gown properly, and allow it to unfold away from the Mayo stand so that you don't contaminate the front of your gown. And then using a swimming motion, you're going to put your arms into the gown, and the circulating nurse or a non-sterile person is going to fasten the Velcro at the back of the neck and the ties at the back of the gown. you'll take a step towards your mayo stand. Remember, you don't want to get too cozy with it because that card is on the front of your gown and you have that wrap that's hanging and draped over the mayo stand, and you don't want those two to touch, okay? So once you get your gown on, you're going to make sure that you keep your fingers inside of that cuff, and that is when the closed gloving is going to happen. Remember, we orient the glove palm to palm or thumb to thumb with the fingers facing the crook of the elbow. And then we're going to grab each side of the cuff, flip the glove over the hand, and gently pull the glove on. It's like magic. Trust me, you guys will get this. It'll just take a little bit of practice, okay? If you were double gloving, typically the half size bigger, so my size is 7, my half size bigger would be 7.5. If I was double gloving, I would first put on the 7.5, and then I would put on the 7 on top of that. Assisted gowning and gloving is referring to us gowning and gloving the other sterile surgical team members. So the surgeon, first and foremost. So we will learn the technique. We're going to have the surgeon's gown and gloves on our field. If they are wet, because they have performed a traditional surgical scrub, you will be prepared and waiting with a towel. You will pass the towel, and then you will put on the surgeon's gown, and then you will help the surgeon put on their gloves. You'll put the gloves on for them, okay? And then you can turn with the surgeon. Two sterile people can turn the gown with each other, or a non-sterile member can turn with the surgeon as well. Opening a case. So we've talked about today, and we watched a video on opening the case. I did put those in the Blackboard. In week 2 content, they should be all the way at the bottom. So if you have questions about opening back tables, peel packs, basins, wrapped items, then that is a really good video for you to refer back to. It also shows how to open instrument trays as well. Remember, when we open sterile items that have flaps, we want to orient the item so that that first flap goes away from us. Then we work with the sides, and that last flap is going to come towards us. With peel packs, we want to commit to our grip. We're going to break the little seals on the side. We're going to get our grip. We'll break the seal of the peel pack, and we will continue to open without letting that peel pack close. We're also going to pop the item out of the peel pack because the area where the peel pack is sealed is considered not sterile. So we don't want that item to slide off the package and onto the field. We want to use a popping technique so that the item inside the peel pack does not come into contact with those sealed edges. When we are opening sharps, we want to open them in a very conspicuous place, a corner of a table where there's no other items, or in a separate pan or basin. Some facilities do not want the sharps opened onto the field, and their policy is for you to set them aside, and the nurse will open them to you once you get scrubbed in. So again, when in Rome, do what the Romans do. Ask the facility, your preceptor, your nurse, what their practice is, okay? Some other considerations. Like I mentioned before, contaminations are going to occur. If a gown becomes contaminated and it's not specifically on the sleeve, then the entire gown and gloves will need to be replaced. If a glove becomes contaminated and you are double gloved, it is fairly simple to remove that outside glove or have your circulator remove that outside glove, and then the circulator would open you a new pair and you would simply just replace that glove. If you are not double gloved and you are single gloved, then the nurse will still remove the contaminated glove, open you new gloves, but instead of using a closed glove technique to replace it, you will revert to the open gloving technique. And we will practice this in class as well. If a sleeve of your gown becomes contaminated, there are sterile sleeves that we can use to cover up that contamination. The sterile sleeve is similar to the sleeve of the gown, but it's open on both ends and it has elastic on both ends. And it's kind of folded, it like rolled inside out. So you put it on and there's a cuff, and that cuff allows you to keep your fingers protected as you move it up your arm. Sometimes the surgeon's sleeve, gown, glove will become contaminated, and it's your job to call it out if you recognize it, first of all, to communicate to the circulator the new supplies that you need. Ask the circulator to help the surgeon either remove the gown or the gloves or both and get you new ones. And if it's a sleeve that's required, the circulating nurse would do that as well. And then it's your responsibility as a surgical technologist to re-gown or re-glove or sleeve your surgeon or surgical assistant, whoever it may be. As far as evidence-based practices, we kind of touched on that at the beginning of the lecture, but evidence-based practices don't rely on past practices to define current ones. As I said, it relies on science-based proof rather than opinion or tradition. So what are some things that we ask in regards to evidence-based practice? There's 3 things. Why is this technique used in this situation? What is the rationale or logic? Why? Why do we do this particular practice or procedure? And then lastly, is this the best way to accomplish this? So once we answer these questions, we have the framework for an evidence-based practice. Some examples that the book gives us are double gloving, the surgical hand scrub, and annotated research. So double gloving. In the past, double gloving was only practiced in certain situations, like orthopedic cases. We're handling saws and chisels and things with very rough, pokey, cutty edges. All right, bones have sharp cutting edges. So traditionally, orthopedic surgeons double gloved. Or if you heard through the grapevine that your patient had something really scary that you didn't want to get, like this patient has Hep C, or this patient has HIV or AIDS, then we're like, oh man, we better double glove, all right? However, the current practice has become that all scrubbed personnel wear 2 pairs of gloves regardless of the surgery, regardless of whether the patient has something or doesn't have something, okay? Surgical hand scrub. Historically, we wanted to scrub for 10 minutes, all right? That was the best practice. What they found was scrubbing for an extended period of time not only breaks down the skin, but it also stirs up the resident flora that lives deeper within the skin. Okay, so studies show that the surgical hand rub is a best practice, all right? So we still do our traditional one, like I said at the beginning of the day, or if we leave the department, or if our skin becomes visibly soiled. Otherwise, we refer to this surgical hand scrub in place of, or the surgical hand rub in place of the surgical hand scrub. Lastly, annotated research. Professional journals, textbooks, they have a responsibility to publish information based on research and evidence, not opinion. All right, if I was going to write a surg tech book, I couldn't write, well, I think we should still scrub because I feel this way or that way, right? Annotated research, it's not touchy-feely, it's as devoid of bias as we can possibly be, and we want to use information that's been published in a timely manner. So we typically look at no more than 5 years from our current year, right? So if I was going to be doing research on something, I would want to look at references that were published between 2015 and 2020, or maybe even 2016 and 2020. This is going to give me the most current, most applicable research. And that's why we need to update textbooks and other journals and publications, is because those sources that were used become out of date. So that brings us to the end of our discussion on Chapter 9, the principles and practices of aseptic technique. So what you need to do as a group is have a discussion of some of those things that are still unclear. What are some concepts that are still muddy that you need an extra explanation or visual or something? And each of you need to come up with 1 or 2 different muddy points that you are then going to post in your group discussion, okay? Also, you will be completing as a group the case study on page 178. There are 5 parts of that, so you can just create a Google Doc and then somebody can post that link to the threaded discussion. But make sure that each of you post muddy points individually, and that will help me to discern the things that are still unclear that I need to talk about when we meet next week in our live online learning session. Okay, so I hope that this lecture was helpful and that you had some good takeaways, and I look forward to addressing those muddy points or those unclear areas for you.